everyone. I would like to start with the afternoon session with my talk. My name is Bron. I'm the Chief of the Flight Surgeons at the Swiss Air Force, located just behind Zurich. I'm presenting more the German part of Switzerland, but I'm bilingual, but I'm working close together with the cardiological expert Thomas. You have heard the talk this morning. First, always a question. So take your clickers. It's the first question in the afternoon. There's only a yes and a no, so we make it easy.
Sorry, 2-6, we have the wrong one up there.
That's the wrong question.
That's the one we want.
The question is a parachutist with a bradyarrhythmia disturbance with a sinus pulse fit for his mission? And here, normally I showed the EKG, but it's not there anymore. But just because it's probably we can.
It's okay. We'll switch back just to 2-6.
Okay.
Keep voting. The voting's still open.
Look on that EKG. We can switch back, and please click on yes or no. Yes, it's 1, and no is 2.
Asymptomatic, right?
Asymptomatic.
Okay.
Okay. Thank you. So 75% said no. Let's see how it works. So that's the agenda for this afternoon. First, I will start with a case report, and then I will go very systematic through the written disturbances and in especially addressing the medical risk management. First case, that's always good after lunch. That's the 20 years old parachutist. It's an aspirant. We saw in the EKG a bundle block, delayed air progression, some ST changes in V2, V3, but most striking was the Sokolov line index with 5.2. The ergometer was normal. We do normally EEG. There we saw some disturbances where further examination was recommended. The echo was pretty normal. Based on that standpoint, fit for his mission. The 24 hours EEG reported bradyarrhythmia with pauses up to 4.7 seconds. Further cardiological examination has been done. Here, just a picture of it with a pretty long pause. Here, the same EKG what you saw before. And the cardiology report was mentioning an intermittent distinctive bradycardic rhythm disturbance with sinus pauses up to even more, 6.5 seconds, due to a vagal symptomatology. Main question again, is that guy fit for his mission? Yes or no? You need to decide. We will come up with that question again to the end, and then let's see what you are deciding. Now we are changing to the thing we would like to pursue here, as mentioned before. That's the program for the next couple of slides. In general, how we are performing it on the Swiss Air Force, and especially the risk management. First, Switzerland is acting not anymore on the JAR, is acting under EASA. That's since June 1st of last year. Personally, I couldn't see any big changes. 1% rule is still active. So, what we are doing in general is first asking the question, is he under EASA conditions fit, yes or no? If there is a no, it's pretty clear we cannot pursue actually this thing as a military pilot. Then second question for the risk assessment is always, what kind of aircraft is the person flying? And last question, what kind of mission does he need to accomplish? And here the general risk, as we heard yesterday, the afternoon talk, and this morning. Now to the first topic, with the ventricular premature beats. First, we are looking in our normal recordings if there is a premature beat, yes or no, and if there is more than one, further action is needed. In general, the higher the age, the more probable of an arrhythmia is there. Here we cite just our PC-21 indication aircraft. Then, secondly, we are looking if how their form is looking. Is it a multiform variation, a multifocal variation, are they couplets, are they cells? And then further cardiological examination is required, like an echo, like a Holter, or an exercise EKG. Then, when the ventricular premature beats are below 200 an hour, that may be acceptable for a non-invasive investigation. But the complex arrhythmia may require a multi-crew limitation due to inability to predict actually the outcome. Second, SA diseases, sick sinus, Brody, tachycardia syndrome. In young people, they are pretty rare. We have primarily affected SA node and atrial myocardium. We have typically abnormal pauses, but overlap with the athlete heart that may remain oligosymptomatic over years. But the problem is always the thromboembolic stroke. And for sure that's not fit to fly. The procedure looks pretty clear. We do a regular exercise EKG, we do a Holter, we do an echo to confirm a normal structural integrity of the heart. As you heard this morning, too, valve disease. For the licensing, a multi-crew limitation is actually recommended, for sure in a jet that's not possible, there we have a problem. But once the thing is symptomatic, certification to fly should be denied. Next topic. the abrupt onset of arrhythmia, maybe to a pilot, is very alarming. This distracting incapacitation is possible, and subtle is or maybe obvious. Depends for sure at high rates. Systematic hypertension may occur, G tolerance may be decreased and lead to sudden incapacitation. For sure, different possibilities are there, like myocardial structural abnormalities. Next topic, atrial fibrillation. Most common rhythm disturbances causing intermittent or persisting symptoms. For sure, structural myocardial abnormalities may occur. Here, the prevalence you see, age is increasing, so the incidence is increasing. Here are some causes. Infection, for sure, alcohol abuse, hormonal changes, myocardial diseases, valvular heart diseases, as you heard this morning too, and for sure, the cardiovascular diseases as a risk. Recertification, first of all, for sure, needs to be asymptomatic. Needs to be again in a sinus rhythm. The hormones should be normal. And for sure, negative history of a TIA. Risk factors, and for sure, normal cavity and structural dimensions, normal Doppler flows, and for sure, Holter EKG over 3 months without any AF period. Recommendations are, for sure, multi-crew only. But the reality shows, for sure, almost none of the applicants with a G. What kind of drugs are permitted during that time? You see it here above, but the non-permitted antiarrhythmic drugs are here below. For sure, in general, all the medications should be taken without any side effects. That's normal too. Here are some risk factors for thromboembolic stroke. In paroxysmal or persistent atrial fibrillation, age is one of the biggest risk factors. Diabetes, positive history of previous TIA, decrease of ventricular function, coronary heart diseases, and changes in diameters. Compared to that is the arterial flutter. Often a continuous re-entry circuit around a ridge between the orifices, and there you have a rate something around 300 beats per minute. Commonly 2-to-1 conduction. There you have abrupt ventricular rate changes, troublesome symptoms. And for sure, under those conditions, he's not fit to fly. As a therapy, you have the radiofrequency ablation of the atrial flutter. And that for class 1 is unrestricted, may be considered if there is a symptom-free interval after 12 months. but for sure exercise EKG is normal, echo is normal, Holter is free of flutter, EPS demonstrates a bidirectional isthmus. The reciprocating tachycardia is most common actually in a single cause of regular narrow complex tachycardia. Cause is the micro re-entry therapy with 2 pathways, and the rate is at 200 beat per minute with symptoms of breathlessness, chest discomfort, polyuria. Natural course, there you have a recurrence, and for the certification shall be assessed as unfit. For sure you have expectations through slow pathway modifications and so on. Here the atrioventricular reciprocating tachycardia. The cause is an extranodal fast conducting pathway, the so-called Kent bundle, and there you have the typical delta wave where you have the VPV syndrome, and if you don't have it, it's the LGL. You need to look and search on it, otherwise you cannot find it. And typically the PQ is below 200 milliseconds. First, I'm always doing the pilot as an unfit modus when you have detected it, and then further studies needs to be done. And could be redone as fit if there is no history of arrhythmia, the echo is normal, exercise EKG, Holter are within the limits, could be set as fit within the OML restrictions too. The unrestricted class should be if there is actually a positive history of a re-entrant tachyarrhythmia certification, and the ablation is successful and there is no period again. And nearby at the end, but we need to face the general pathies too, so that we have the whole list. Because it's pretty well known, inherited, prevalence is not so clear, but we have a channelopathies, and it's pretty much associated with the ventricular tachycardia torsades and some death. Here as an example, the Brugada syndrome, right bundle block, ST segment elevations, typically. Most common cause of sudden death in young. Most important, there needs to be an active thinking of the diagnosis, and the prevalence is not clear so far. In separation to that, the long QT syndrome may be congenital or acquired. We have different genotypes or phenotypes. All the risk for a syncope, a ventricular tachycardia, and the outcome related to the QT. And you have pretty much a high percent of carriers of gene who have actually a normal QT interrupt. And 50% of those are actually asymptomatic, but 5% may die suddenly. What are we doing for the certifications? Should be actually sure the genotyping is an important detection factor, and especially for the risk management, but those people need to be asymptomatic, have no family history. In the EKG the features should be minimal and should not having any evidence of ventricular rhythm disturbances in serial halters. And initial issue of a medical, for sure the genotyping should be part of the examinations. We are doing here, in most cases, a multi-crew license only. Thank you for your attention. I'm coming back to the question. And if you have other questions at the end, there is still time. So, the parachutist again, you know the EKG, you can type on yes, that's A, and B, that's a no. I think that was not the result.
Voting's open.
Okay.
Any more takers?
Okay, pretty much the same. What I've decided in that case is actually negative for resolution, so I'm joining the 75%. And do you have any questions?